Hey, what's up, everybody? This is Dr. Jeff Moore, currently serving as the CEO of ICE. Before we deliver this episode for you, we got to give a shout out to our show sponsor, Jane, which is a clinical management software and EMR. Now, we all know that choosing the right EMR can be a bit overwhelming, especially for those of you who are just starting out. You're trying to juggle it all. The practice, budget, it's not the easiest combo. That's why Jane came up with her new balance plan. It includes the essential features you need to keep things running smoothly in your clinic without extra stuff you don't. But one-on-one telehealth, unlimited support, email reminders, and more are included no matter which plan you choose. So, if you're looking for an EMR that helps you focus on your patients, not your costs, Jane is here for you just like a part-time assistant. Plans start as low as $39 a month in the US. Head over to jane.app/pricing to learn more. And if you're ready to get started, use our code ICEPT1MO at sign up to get you that 1 month grace period on your new account. Thanks, everybody. Enjoy the show. Welcome to the show.
Thank you so much.
What is your 5K lifetime goal as far as getting, you've been running, I've seen it on the gram.
Okay. Yeah.
What is your lifetime goal for a 5K? Where are we now and what's the goal?
Okay. So to tell anybody that I am a runner is a blatant falsehood. I am running, but to say I am a runner,
You've been running quite a bit.
I have. I'm prepping for a marathon, but I'm going for the participation medal.
Right? Why the choice to do the marathon?
Because I have too high of expectations of my resistance training performance.
Interesting.
I had to move away from competitive sport.
Okay.
And I had to do something that I had no expectations of my fitness level on. And that was running, because just being able to run 10K was a great goal. And then it was a half marathon, and now it's a little bit longer. So it's been a way to prep out or go outside of my competitive era and enjoy fitness for life.
Pressure free.
Yes, exactly.
Prior of this little endeavor, what was the longest race you've ran?
A 5K. And I had done it like 21 or 22 minutes in my CrossFit career.
Is Nick in on these shenanigans?
No. He says that it's stupid. He's like, why are you running for that long? He's like, your toes get bloody. You are like, you're having rectal cramping in your half marathon. Like, none of this is making him want to engage with that type of exercise with me.
Sure. When is this marathon?
The May 23rd, 24th weekend. So it's the same weekend as Coeur d'Alene. It's the same weekend as Coeur d'Alene, but it's like 60 minutes from my house.
Okay.
So it's, But also, you have me on the road like 5 out of the 6 next weekends. So I'm trying to like long run in between random work weekends and getting back off planes and other job obligations and kiddos. So to say that I'm prepping for a marathon, everyone says, oh, it's such an intense process. I was like, let's take that with a little bit of a grain of salt.
We're taking it casual.
Yeah.
What's the longest we've done so far?
17.2 miles.
Oh, shit.
So I've gotten there, right? But okay, so you're going to like start this off making me look like such a dummy, but I was like, I'm smart in other areas, I really promise. But so with running, when you do a CrossFit competition, you kind of just eat the same way you've always eaten. But when you start going into long endurance, you really have to be intentional about water, salt, and fuel.
For sure.
And I was like thinking, I'm a newbie. I'll just eat whatever's on the course. It'll be fine. The gels there tasted like Nutella, which were disgusting. So I didn't eat anything. Horrible mistake. Mistakes were made. I've gotten better. But now you have to eat like 1,000 calories when you're running that far. I have been stuffing my pants with gummy bears and stuff. Like I'm not the person to look to for any type of running advice. Like that's not me.
I love this for you. And we can track you. Now the audience can track you next month, getting after it, marathon style.
Way to make me out to be an expert right at the beginning.
Great start. Great start.
I recognize where my holes in knowledge are and defer to experts in my non-areas of expertise.
And that's important. Okay, let's talk about your area of expertise. So your PhD is so unique in subject matter. Tell us why. First of all, tell us what it is, but then give us a little bit of backstory into it's not an area that has been well covered. What's the genesis? What got you into it? Why that direction?
Yeah. So when I first started as a physiotherapist, so I'm our resident Canadian. So when I first started in practice about 10 years ago, I went into the traditional orthopedic model, right? Manual therapy, fairly focused, a little bit of Therex here and there, and ran a really prosperous clinic. I really liked working with our older adults. I always thought I would go into neuro. I never did. And I kept seeing this problem where people would do manual therapy. They would do a bit of strength training that would get them back roughly to baseline. Their pain would be relatively managed. They would decondition for the 3 months in between being discharged, and then they would be back on the caseload, right? We see that. The frequent flyers that come in and they finish their plan of care, they wait until they go back to their doctor for another one, and they kind of come in with something else. It didn't really make a lot of sense to me. I said there had to be another model. At that time, I was in like OG CrossFit, like 2012, and I was working as a PT in a CrossFit clinic. And there I got to see not only CrossFit athletes where I was working with, CrossFit-based injuries, but I got to see their parents. And in that model, I got to get a little bit more freedom. Like I would start doing a bit more high-dose exercise in the clinic, and I would get pushback as the new grad saying, I don't know if you should be doing that. Like, I don't know if you should be pushing them that hard. But in the CrossFit clinic, like they didn't really care, and I had a lot of freedom. And so I finished working with our older adults, and when I discharged them, I ended up starting a program called the Boomers. And in that class, I had somebody with an inoperable AAA, somebody who was trying to avoid a knee replacement, somebody who had uncontrolled diabetes, somebody who had had a stroke, and they were all in the same class, and they had an unbelievable amount of recovery. And I would just kind of model and shift and scale things for their capacity levels. And they never had to go back into PT because they were doing some sort of continuing care. And my husband says that I'm never allowed to say, I'm just going to send an email, because that means that something life-shattering is about to happen in our world. And so I started looking at the research of this, of saying, where is this hybrid where we can start to build reserve and capacity around joints, around specifically older adults? And I said to him, I'm just going to send an email to talk about this research. And within like 4 weeks, I was enrolled in a PhD program. And so what my PhD wanted to look at was, how can we build capacity and long-term resiliency in our older adults? And I don't think traditional Therex is it, right? We always talk about building the buckets of reserve and capacity. And so how can we do that in our older adults? And the barrier ended up being, well, we don't have any evidence to back us up. And in very clinical, very chronic, very sick populations in particular, those vulnerable populations, if we don't know, the answer is no. And because that was the case, I was thinking that I just had to go to the source and generate that research in general.
Who did you send this email to?
My supervisor. Who she ended up being my supervisor. So I went back to my alma mater. I did my PT degree at McMaster. And so I sent an email to one of my professors and said, hey, I think I want to do a PhD. This is the area that I want to work in particular high load resistance training for our older adults. Is there anyone that you think would sponsor me or be my supervisor? And the answer was yes.
You were, from what you were seeing in practice, the revolving door, these folks coming back in 3 months, seeing the other side of that in this boomer group, you were convinced enough, like, I want to do a multi-year program looking at progressive, like pushing these folks harder to change these folks into these folks.
It sounded like it could be pretty fun.
Yeah. And you reached out and they thought it would be fun as well. They were responsive.
Yeah.
Was there any like, hold on, we don't want to get in that space, it is dangerous? Or were they, to their credit, up for it?
No, to their credit, they were up for it. And so my PhD supervisor, so I went into a part-time PhD and I was working with Dr. Ada Tang, and even more to her credit, she was a predominantly stroke researcher. She was not working in older adults generally, and my area, which ended up being frailty. She was working completely in another area, but she was a new tenure track professor. She was looking for PhD students. Mm-hmm. It is helpful, or especially in a rehabilitation science program, to have a PT PhD student or candidate, because there's a clinician scientist role that has a lot that it offers with that clinical context. And I also got very lucky that she allowed me to go part-time, because I didn't really want to move away completely from clinic. Yeah. And so a lot of people who start part-time PhDs, because it is like, it was a 6-year process. I had 2 kids in the middle. I had a business in the pandemic. Like you had me trying to travel and I was in, like, it was just kind of a nightmare.
Yeah.
There was a lot of times where I didn't think I was going to get it done, especially because I wasn't thinking that I was going to go into academics. I wasn't trying to be a prof. Like, I was well situated in working with ICE. I still am.
What were you thinking you were going to do? I mean, when you set out to get this additional terminal degree, what was the...
It was literally for fun, Jeff.
Wow.
I did it for fun.
It's kind of like you're running.
Why would you run 3 hours with no skill in it?
That's
I don't know.
Fantastic. Okay, so there really wasn't.
No.
You weren't thinking, I see myself being a professor. You were having success in practice.
No.
But you felt this area, you were curious, and you felt like the area had to get looked at.
Yeah, and so my PhD was doing a pilot RCT that took individuals at risk for frailty and put one into a moderate RT group, so moderate resistance training group, similar to our exercise guidelines, and one into a high load resistance training program. So squats, deadlifts, step ups, rowing, a bunch of other barbell related exercises, things that we see in functional fitness gyms all the time. And my main goal was to look at safety and effectiveness. And what we were able to show is that these at-risk older adults can very safely get into these types of resistance training programs. And that was step one, because when we don't have any data, we have to pilot test it before we can go into bigger RCTs where we can get the statistical power to think about, is there going to be a verging off of effectiveness where high load may be superior to moderate intensity?
So before running that, the IRB didn't say, hold on, we need some sort of a Delphi inquiry or some sort of a questionnaire where we get practitioners' opinions that it's going to be okay. You were allowed to go kind of right into actually setting up a prospective trial?
Yep, we were, which is kind of surprising looking back on it, especially because now where my research is in pregnancy, there's a lot more hesitancy that we've had to push. I think that there was kind of a lack of probably true understanding of the loading that I was talking about, because you say 5x5 at 80%, people don't really have a real big understanding that I meant.
But in reality, for someone who...
I had some of my 85-year-olds lifting over 100 pounds by the end of their 12 weeks. And they were just rocking it. Yeah, they did an incredible job.
Okay, talk more about
reserve.
exactly what they did. So what was the exercise program?
We mirrored it off of Shauna Watson's Lift More trial.
Yep.
So it was 5x5, 80 to 85%, RPE of 7 to 8 out of 10, big barbell movements.
Which ones?
Deadlift, squat, step up, pressing, like bench pressing, rowing, and overhead pressing.
How was that structured? So like that wasn't all in one session?
No, twice a week, 60 minutes, half one day one, half day two.
And half the other one.
Mm-hmm.
How did you find their maxes? Did we estimate from a 3, or did you actually test them out?
No, looking back, we should have,
Yeah.
but we did motor control. So we just kind of taught these exercise motor patterns rather, and then use RPE to build intensity.
Gotcha.
So because they hadn't had any exposure to any resistance training, we couldn't really 1 rep max them at that point.
Totally.
But, hindsight's always 2020.
Yeah.
I would go back. There's a lot of things that I would have
Sure,
done
of course.
differently. Now, especially now having just way more experience within the geriatric space and then the research space in general.
And you carried that forward for months?
For 12 weeks. Didn't have a single injury. Everybody
How many
is
people?
super
How
great.
many people in the trial?
We ended up having about 50
How'd you recruit them?
through the friends of everybody in our CrossFit gym. It
So,
was
I mean,
actually so easy to recruit, which one of my pet peeves about rehab providers is that they'll say, oh, well, the N is small. And I was like, listen, bucko, until you have actually tried to recruit individuals who are vulnerable and in pain to be in a randomized control trial, don't come at me about the recruitment. Like, it can take so long to
How
get
was retention in the group?
It was great. Our adherence was over 80%.
That's fantastic.
And so we got safety, feasibility, and applicability in our group, which was fantastic that we were able to, see that come to fruition.
And what were we putting in the control group? What were we putting in the other arm?
Moderate intensity. So we were doing 2 to 3 sets of 8 to 10 repetitions, single joint isolated movements at a 4 to 6 out of 10.
Oh,
RPE.
That's not nothing.
No, it's not. And actually, it was one of the things that I got dinged on my defense. Right, one of my committee members said to me, "Why did you compare a high load group to another appropriately dosed exercise group when only 13% of our older adults are doing anything to hit the exercise guidelines and usual care or usual activity is doing nothing?" And my response to him was, we have spent billions of dollars of research money to say that doing something is better than doing nothing. And I felt like it was a waste of time, right? We see all of these low-dosed research programs, which translate into low-dosed conservative care providers, because they compare them to somebody doing nothing.
And you make a great point, because had you done that, people could have said, well, she didn't need to go that hard or that heavy, right? She could, and you couldn't have really proven otherwise.
Right. And so after the pilot trial, what could have been our next step, which I haven't gotten there yet, and my postdoc ended up switching gears, is you build a higher power RCT, which is 3 arms. Yeah. So high load, moderate RT, and then a control group, which is like a home exercise program or a walking program or something that isn't kind of with the goal of strengthening muscles. Yeah.
Okay. What adverse event wise? 12 weeks. And for those who are listening that aren't familiar with the weightlifting space, like, you start getting up around 80% and you rep it out multiple reps. Like, these people are trying very hard. I mean, this is serious exertion. And it went fine.
It went great.
Nobody had an issue?
No, we had one person who had a low back strain, but it was DOMS.
Okay.
And so, so here's like the funny thing about being a clinician scientist. I have to report that as an adverse event. Having when they come in the next day and they say, my back, like those muscles around my back were really sore, I have to report that as a minor adverse event in the trial. And my clinician hat is like, come on, why is this an adverse event? But we see it in our exercise studies, right? Totally. Around adverse events being around muscular soreness. Yeah. And when I'm taking a person who hasn't done any exercise for maybe years or maybe ever, and I'm getting them into a high load resistance training program, I'm expecting some DOMs.
I would hope so.
Almost.
I hope so.
Exactly.
Hard to avoid that.
Exactly. So it is interesting, even how like research is reporting things, and then what I think about it as a clinician. Whenever I'm teaching a course, I always say, okay, I'm putting my clinician hat on right now. Yes. Here's how we're going to interpret this. My research hat is telling me that we have to standardize everything, and this is the answer. My clinician hat is like, let's kind of shift this a little, because it doesn't really work when we put it into actual practice.
Totally. So primary outcomes, I mean, outside of, hey, they didn't get hurt, what else were you looking at in reporting between the two?
Yeah, we were looking at, we got the mini best, the Berg balance, timed up and go, some of our standard geriatric outcome measures. We saw some improvements in both groups, but we didn't see any deviation between the two of them. Okay. And that was kind of what I would expect for the size of the trial and the length of time, being that both of the groups were appropriately dosed. Yeah. So we saw some improvements, 6-minute walk, SPPB. Some of our balance outcomes did well, but nothing that was statistically significant between groups.
Okay, so you rock this trial. How long did this whole process take? So like from the moment of the email until this trial is done, how much time is elapsing here?
So getting the trial done was probably my first 2 to 3 years of my PhD.
Whoa.
And then, and that's like you're taking coursework. Yeah. I had to do a comprehensive exam, which included having a whole other research area.
You said, it's part-time. You're trying to do it in a reasonable...
Part-time.
Yeah.
I had started Stave Off our clinic, which was a business model.
Why not start a business during all that? That adds up.
I know, but I had to put it into practice to see if it would actually work.
It's logical.
It was logical.
For sure.
Right? And so I took this, what I was doing my pilot on, and I put it into a business model. And
Nick
then the
was
business
right. Stop
model...
sending the email.
1,000%.
Sure.
1,000%. And that business model thrived too, just to actually, show that this works in practice. And that was about 2-3 years. And then it got a lot slower as babies started to come and getting stuff out and all that kind of stuff. So it probably took me like 6-7 years plus maternity leave to get my PhD done.
Who were you working with on this trial?
Well, it's funny. My husband was actually one of my assessors.
That's awesome.
RCT. He said that he deserves a P after his name because he was Nick, he was like my emotional support human, and he was also in the trial, and he was like there every step of the way. So we had some kinesiologists who were helping us with the assessment. Mm-hmm. We had myself, I was running the exercise program for one arm. We had a second arm that was in another gym in Collingwood, Ontario. And then my supervisor was helping with like grant funding and things like that. Yeah. So we had a team of like a research assistant, my supervisor, and myself, and then a group of volunteers who were more in the kinesiology space, wanting to become physiotherapists, that were helping me with the trial itself.
Awesome. So would you say it was a win? I mean, I can imagine some of our audience listeners saying, well, it wasn't better than the other group. Like, they didn't get hurt, which is good. is the win that we're taking from this, but they didn't get hurt, and we know what high intensity does, even though maybe it didn't pop out with the things that we were tracking and stuff. We know the potency of that stimulus, and now we know it's safe for that population. Like, is that sort of extrapolation where the money is?
Whenever we're thinking about evidence, we always have to build it.
Yeah.
Right? We have to build it. So the first thing that I had to show was that it's safe to do it. And a lot of people don't understand that. Like, I have to give the foundations before I can ever go into more of the trenches. It's like our high intensity interval training research. We started in general populations, athletic populations. Then we went into really healthy older adults. And now we've got research in cancer patients and COPD and multimorbidity, subacute stroke, heart disease, et cetera, et cetera. So that for me was a huge win. From my clinician hat, I needed the justification that I could do high intensity interval training. And now my research hat says it's safe, and my clinician hat says it is a hill that I will die on, that our older adults need to load heavy.
And you had empirical data from the fact that some folks were revolving door that weren't doing it, and those that were doing it weren't. Yeah. And
so then now, as a clinician researcher, where I die on this hill is that what I see in practice is that, one, there is a lot of fear of heavy loading. And so if I can get individuals in the clinic to supraphysiological loads, so loads over and above what they're ever going to expose themselves to in activities of daily living, they are not going to disengage from activities of daily living because they're not going to be afraid of them anymore. And that is a huge hill to die on. You can do 3x10 at 3 pounds. That's not going to make you want to take that 3 pound sandbag. I don't care what your estimated 1 rep max calculator tells me. Right? Because there is a difference in
psychologically.
Yes.
Totally.
Yes. And then in that high load, low repetition range, we're seeing that it's purely muscular for my older adults who also have cardiovascular deconditioning. As soon as I'm getting into 12, 15 reps, sometimes their volitional failure is because their heart rate is jacked. And that's not the case necessarily at higher loads. So the mental health piece, the graded exposure to fear piece, the confidence to engage in activities of daily living, those are all reasons why now that I have this safety data that's showing me that it's okay, I'm going to push my older adults. And now I have this clinical base that I've done over 10 years. I have this evidence base, and then obviously my clients' desires and wishes are going to be the third part of that evidence-informed or knowledge-informed practice.
I love that. I want to go forward in a second, future, but I want to back up to one thing you said, that you were building off some previous research, the LIFTMORE trial. Can you speak a bit to what was unique about what you did, what they had done, just to kind of bring us up to where we are as far as what's on board?
Yeah, so the LIFTMORE trial was published in 2019. And it was very revolutionary because it was taking individuals with moderate to severe osteoporosis, so T-scores of -1 to -2 at the femoral neck and lumbar spine, and putting them into a high-load, high-impact strength training program, again, compared to a moderate intensity control. When we are taught about osteoporosis in school, we are taught about all the things not to do, right? Don't bend, lift, or twist.
Totally.
Make sure that they don't get to a point where they could have a fracture. This flipped that framework and said, hey, our muscles respond to load, so we load them. Our bones respond to load, so instead of recommending Aquafit, let's get them loading and build the tensile strength of the bone, right? And they put them into a 5x5 at 85% program, very similar of the squat, deadlift. They did the only deviation that I had was that they had done a jumping pull-up with an impact landing. And we weren't really looking at impact as an outcome. Yeah, we pressed instead. And their program was 8 months. And so over 8 months, they were able to see greater benefits in the high load group than the low load group, which is why I say my 12-week probably was insufficient to really deviate or tease apart those differences. In their 5 times sit to stand, they did a vertical jump, like kind of all of our geriatric outcome measures, they got better. The other piece of that was not only did they not have any fragility fractures, there was no increased risk of adverse events, but their bone mineral density actually improved at the femoral neck and lumbar spine, where we saw the natural, I'm air quoting if you're listening to audio, decline that we saw in the moderate intensity group in bone mineral density if we're not doing any type of intervention to help stimulate the bone. Then they replicated that in men. So that got published about 18 months later. And now we have a group in Canada, Laura Jean-Gregorio is doing further research that is trying to tease apart, was it the impact part or was it the load part? And so we're again building on that level of evidence in a clinical population.
Nice.
And so there was a lot of similarities between that trial. We were trying to do it very broadly to a geriatric population versus an osteoporosis.
Yep.
And so pre-frailty is a very big eligibility criteria.
Yep.
We wanted to kind of encompass more community dwelling older adults who are at this tipping point where they're starting to experience difficulties with things that they used to do. They are self-selecting to do less in a day, and their life can converge, and it can go in one route where they continue to gain capacity and keep up with those things, or they can kind of slide and they can start to lose capacity. And that really, again, coincides with a lot of what we're teaching, which is around this concept of 1 rep max living and how do we boost that up.
Love that. Okay, so you build off that, you finish your trial, it's a success. Folks aren't getting hurt. Now you've got the trifecta. You already had your clinical experience. Now you've got some data and you've got patient desires. We have the evidence-based trio. Where do you go next with your research? So that finishes up what happens now in the Christina Prevett research life.
Yeah. So then I kind of converged and I kind of went off in a different direction because I got pregnant.
Yeah.
And so I got pregnant with Maya. I was a national level weightlifter at the time, and I was doing some work. Okay, let me come back.
Yep.
My comprehensive exam, one of the things I was really interested in is where we have evidence for rehab in health and wellness. When we think about prevention, we have primary, secondary, tertiary prevention.
In comprehensive exam, you mean in the PhD program?
Yes, in the PhD program, sorry.
Yep.
We are predominantly in tertiary prevention. So something has happened, we're trying to get them back to baseline, or they get a chronic disease, we're trying to make it not get worse.
Yep.
Right? Tertiary prevention. Primary prevention is like public health. Overall, trying to get humans to be adhering to more lifestyle factors. Secondary prevention is we're trying to get individuals who have risk factors for chronic disease to not get that chronic disease diagnosed. And then we have tertiary prevention. And so I did a scoping review that was looking at where we have evidence for rehab in primary and secondary prevention. Where can we get involved in the wellness space?
Yeah.
I don't talk about this a lot, actually.
I love this. Yeah.
And so obviously falls prevention in older adults popped. Chronic disease self-management or like workplace health and safety, trying to get people adhering to lifestyle factors popped. And then the perinatal space popped, right? Around how do we keep moms who are going through this big tumultuous period to get back to fitness and have good pelvic health so that they can engage in life. Because of that, and I had this gym-based model that was this medical supervised exercise model. We focus in older adults. We started a program called Strong Like Mom. Again, I took my PhD and directly put it into a business model. So I had gotten into the pelvic space through exercise. And I was this person, I was like, I'm never going to do an internal exam.
Yep.
Don't want to be in a room. Sounds super boring. My finger doesn't need to go into a vagina.
Going to wind up just doing that all day.
Yep. Don't want to do it.
Yep.
Ew. Right?
Yep.
Like that is not going to be my life.
Yep.
And then I got pregnant with my daughter. And I was a national level weightlifter. I was trying to prep for nationals again. And it's interesting because this was, 6-7 years ago where there was a lot of fear around exercise and movement in pregnancy, especially things that are kind of outside of that low to moderate intensity.
Yeah.
And so I had a barbell brush right against my pelvis. And I was like, well, contact is contraindicated for exercise in pregnancy. I'm getting a little nervous. I'm 10 weeks out from this meet and I want to prep for nationals and I want to still do it.
Yeah.
And I had a high risk maternal fetal medicine doc that was referring to me because I did exercise based interventions in the gym. And I emailed him and I said, hey, like,
Here's that email again.
yeah, but this was good.
Okay.
This was good. And I said, hey, like, I really need your advice. Like, this is what I do for exercise. And he says, you are totally safe. That baby is super far back in your pelvis. Your body's used to it. Like, go for it. And it's funny because I just gave an obstetrical grand rounds and he was sitting in the room. And I said to him, I was like, you have no idea that you just changed my career with that one email. And he was about to retire in a month. And so it was like so serendipitous. I was like almost like really emotional because he changed a lot for me.
Yeah.
And then I had a committee meeting, like, big baby bump down the road. And one of my supervisors or one of my committee members said, if you think that there's no research in geriatric practice,
check this out.
Let me tell you. And of course I looked into the research and there was nothing. And of course I was starting to develop a lot of ideas and you guys were getting annoyed with me because I was like, Jeff, like, what about this? And what about that?
Never.
And then I go to Nick, I'm like, I'm just going to send an email.
I'm going to get Nick on the podcast, first of all.
You should. It would be really funny to get his perspective. Awesome. And he goes, Christina, like, you're so busy. I wasn't even done my PhD at this point.
We're running the private practice. We're still in the PhD. We're pregnant.
Yep.
We're trading for meats.
We had just decided that maybe pelvic was going to be a thing in the division. And I was like, I'm just going to send this email. Yeah. And I sent it to Dr. Margie Davenport, who's now my postdoctoral supervisor. And I never said I was going to do a postdoc. I never wanted to do a postdoc. And I said, I have this idea. And like, I don't know why people respond to me sometimes, but she and I got onto a call and I said, here's my space. Here's my idea. We don't have anything in high load training. I'm a PhD student. This isn't my area, but I'm really interested in knowing if there's something we can do. And she goes, well, why don't we do it together? And I was like, that sounds great. And Nick's like, I'm going to kill you.
Now, can you explain what postdoc is? You said you might not never do one. Can you, for the listeners that don't know what it is?
Yeah. So the best way to describe it is a residency program for a PhD researcher. Okay. So the idea is that you finish your PhD, you go into a postdoc area, which is unique and different. Ideally, it's not with your PhD supervisor. It's with someone else. You're learning from somebody else, and they're trying to get you to start your own research program so that eventually you can transition into a tenure track position. So if you're going to go into academics, that's kind of the pipeline. You go PhD, postdoc, and then what you build in your postdoc becomes the launching pad for your tenure track position. And
so we get a yes.
We
and
get
a
yes.
teammate, apparently, at the same time.
Yep. So I ended up, during my PhD, I started a cross-sectional study on high-load resistance training in pregnancy. So individuals who self-selected to lift more than 80% of their 1 rep max in pregnancy. Then we did a bunch of surveys and questionnaires to say, you know, how did your pregnancy go? What was your labor and delivery outcomes? Because there's a lot of thoughts that like you can't lift more than 20 pounds in pregnancy or things like that.
And for the listeners, this type of study design, we're interviewing, we're not running necessarily a trial.
No,
we're gathering data from these folks.
Yeah, so internationally, we just put up a link that people could do on the line.
Whoever meets these criteria, please reach out and let us know how you did.
So we got about 679 individuals came into this cross-sectional study, and we saw that there was no increased risk of gestational hypertension, preeclampsia, perinatal mood disorders were lower than national averages, gestational diabetes was lower than national averages, and generally labor and delivery outcomes didn't deviate significantly.
And what was the criteria? What did they had to have done to be appropriate to give you the data?
They had to self-select to lift at least 80% at some point during their pregnancy. So they were going
at any point during their pregnancy, in any lift, hitting that level of exertion.
Yes. And so we were looking at what were their numbers for squat, bench, deadlift, snatch, and clean and jerk to just give us an idea where they were at. And we had, average squat was like 150, average deadlift was close to 2, average bench was like 80 to 90 pounds. So we had it was a lot of recreational, like moms that were going into the gym. And
it's interesting to think about their mindset because they were largely going against the narrative that's out there.
Yes.
And just sending it.
Yes.
Because they love to do it and they felt like it was right.
Yeah. And so that study got published actually before I finished my PhD. And then I had so many questions. And so I get back, we're in Ontario, I finished my PhD, and I reached out to Margie and I said, I really want to do more. And so now I'm a part-time postdoc. I'm a postdoctoral research fellow at the University of Alberta, kind of shifting gears. And a lot of people think that this is really different, but my big, hairy, audacious goal, my life's goal where I really want to connect these two things together is to take a really integral look at high load resistance training, pelvic floor dysfunction, and hormone status in women. So in pregnancy, we're estrogen high, postpartum, we're estrogen low, menopause, we're estrogen low. And so I want to kind of map this out and try and figure out where does resistance training come in? How do we potentially use resistance training to manage pelvic floor dysfunction, or is there any risk with resistance training to pelvic floor dysfunction? And do it in the backdrop of trying to promote resiliency, reserve, and capacity in women who largely, when they start interacting with medicine, get told to be mindful, do less, be fearful. And, I see these women at 80 who have been interacting with healthcare since they were 30 and having babies, and they got told to do less and don't lift and all these types of things. And then it trickles into how they feel about their body and their capacity when I'm seeing them down the line.
So what do we know and what don't we know right now? So I'd imagine a lot of folks listening are saying, well, sure, the people that reached back out to you did well. If something went wrong, they probably wouldn't have reached out, because they were going against the narrative. What sort of data do we have right now regarding lifting heavy things and actual risk from maybe a group that didn't self-select or that wasn't just cross-sectional or questionnaire-based?
Yeah, so I think to kind of make this a really comprehensive answer, we have to think about what the state of the evidence is and where these recommendations came from first, right? Jess Gingrich and I were the first and second author on a new systematic review that is about to get published. It is not published yet.
Shout out, Jess. Yep.
Shout out to Jess. She's on faculty with me.
Yep.
And Margie's obviously on that paper. And one of the things that I really wanted to do was figure out, where did this 20 pounds come from? Right. It had to come from somewhere.
This age-old advice.
Yeah, it had to come from somewhere. So we did a systematic review that looked at resistance training trials in pregnancy. And we took a look at their dosage, we took a look at their outcomes, and we tried to figure out, what is the benefit of resistance training and at what dosage. Mm-hmm. And to tell you that I raged doing that systematic review is like the biggest understatement of the world. Margie would hear from me saying, I cannot believe in 2024 that an RCT gets published in pregnant women with no complications using a yellow TheraBand. Like, my 90-year-olds in my PhD were using a 50-pound deadlift, and my non-complicated pregnancy RCT that I am reading right now has a dosage of yellow TheraBand or a max of 3 kilos. The baby coming out of your vagina is probably going to be more than the max load that this RCT gave you for 16 weeks with no progression, except maybe talking about regressing as baby.
As it neared.
Yeah,
sure.
As baby gets closer, or you get close to delivery.
Yeah.
To summarize the dosing, it was low to moderate at best. Light toning was a word in multiple RCTs. And as much as I was angry, it was also very enlightening. Because again, if we don't know, the answer is no. And if that's the max in our research, then we're never going to go above that. And we're going to say, okay, well, I feel good as a doctor from a liability perspective saying 20 pounds. Because
everyone else has always said.
Because this is what we got.
Yeah.
Right? And so as much as it's infuriating, it's also understandable, right? When medical liability is something that we have to think about. And so my cross-sectional paper started to put a hole in that and say, okay, well, we're having these individuals who are self-selecting to Letebi. Some of Margie Davenport's work has also looked at some of the other variables around high-load resistance training that are theoretical concerns. So one of them is that as we put more strain on the body, our body goes into a Valsalva maneuver, which is a closed glottis, higher inner abdominal pressure bracing strategy that allows the body to lift more load. However, when individuals are doing a Valsalva, their blood pressure can shoot up to like 200, 220 systolic. Yep. And in pregnancy, high blood pressure, bad. We don't want high blood pressure in pregnancy. So what we had to show was that, one, they're not hitting dangerous thresholds, that it isn't sustained, because the medical profession, if it's sustained after 2 readings 20 minutes apart, then they have to act on it. Gotcha. Or could be medically liable for not treating it appropriately. Yep. And so we had to get this evidence acutely, not just about people in the gyms.
Totally.
So Margie, their first study was on 60% of their 10 rep max, because that's the highest ethics would let them go.
Okay.
So they were able to show that at 60% of their 10 rep max on a leg press, right? So it was easier to grab hemodynamics when your back is...
Those mechanics make sense.
And just like all the things on the baby to trace the baby.
Going to be a lot harder standing up squatting.
Yep. They got there though. They figured it out. But this was their start. They showed that there was no adverse event to maternal and fetal hemodynamics. There was no issues with baby's heart rate that would show that baby was in distress. Then they were able to publish that. Another group did the same thing with up to 50 pounds with an incline bench press, and then they were able to get to 90% of their 10 rep max, and they did it with a squat, bench, and deadlift with a bunch of CrossFitters in the Alberta area. And then what they showed there was that blood pressure did not get up to a dangerous level. Yep. There was no issues with abnormalities in maternal and fetal heart rate, and hemodynamics were not altered in a way that was going to be dangerous. So the blood pressure response was there. That also hit the second concern, which is that they think that when you're doing too much high intensity resistance training, that you're shunting too much blood to your muscles, that you're going to take blood away from baby. Again, like, it's not founded in anything. It's just theoretical concerns. That was able to show again that acutely that we don't have that evidence. And then when they followed them to delivery, these individuals who were in the study, there was no like gross abnormalities or any complications or anything like that was concerning.
Yeah.
So we kind of have these acute studies. now what my postdoc is doing is we're trying to build up our levels of evidence in the high load resistance training space. So I have a retrospective study that I'm currently in data analysis for, where individuals in the first year postpartum upload their training logs from their pregnancy, answer a series of questions, and tell us about their labor and delivery. And then I have a prospective study that's going to take me 3 years to do, where I get people in the first 20 weeks of their pregnancy, and every trimester, 12 weeks postpartum, and then 6, 12, and 18 months postpartum, I'm getting them to upload their training logs and answer questions about how they're doing. So cross-sectionally, there's recall bias. You're right, there's going to be volunteer bias. There's very real holes to that paradigm.
But better than nothing.
But we had to start somewhere and give the argument that, hey, there's this group
a lot of these
people
folks
who
did it.
They're doing it. Yeah, they're doing it. And now we can build retrospective. So now we're building up a level of evidence, and we have prospective. We can go forward, and then hopefully after that we can go into our CT level data. But CrossFit hasn't been that popular for that long. Like high load resistance training hasn't been popular for that long, and so it's just more like the waiting game that it takes time to develop this evidence. And we're getting more and more that's coming out, which is really exciting. And nothing that we're seeing in the literature so far is a cause for concern. But I'm also not a person who is anchored that there isn't, right now, my belief is that our only restriction for exercise that is a blanket statement is don't do any sort of blunt force trauma or contact to the belly. Outside of that, it's individual buoys. But that might be wrong.
Totally.
Christina,
you're open to it being wrong.
Christina of 2028 may say something different than what Christina of 2025 is saying. But Christina of 2020 was definitely way more concerned and talking about modifications. Like you've seen our arc of where we were, and we were like, well, let's be mindful of this and let's do this. In my cross-sectional study, we didn't show any higher rates of pelvic floor dysfunction when those that Valsalva versus those that didn't. And Christina of 2021 was saying, hey, exhale on exertion when you're pregnant because it's putting extra strain on the pelvic floor. And now Christina of 2025 is like, here's your options. And
dealer's choice.
Dealer's choice. Figure out what works for you.
Christina, I've heard narratives that might even go beyond, hey, it doesn't seem like this stuff is risky. Is there a chance that some of this lifting resistance training during pregnancy, could it be not only not risky, but maybe protective or beneficial? Can you speak to that a bit?
Yeah. So the phrase that you're going to hear me say a lot, and everyone calls it this is like a Christina quote, is that being pregnant is hard. Being pregnant deconditioned is harder. Being postpartum is hard. Being postpartum deconditioned is harder. Aging is hard. Aging deconditioned is harder.
Totally.
Right. And so we have this protective effect of muscular strength in general. In pregnancy, there's definitely a conversation that we're starting to have in the research space, and then it's trickling into us in the clinician space of what if our goal is trying to limit deconditioning in pregnancy to optimize resiliency in the postpartum period? Because so many people feel very vulnerable and feeling like they're lacking a lot of strength in the postpartum period. And my question is some of that because us as pelvic PTs overly restricted exercise based on theoretical concerns that haven't panned out? And
heavy.
Heavy. Man, gut punch, knife and twist. And with that, the interesting part is that there's only one study that I can find right now that's kind of looking at this with respect to pain. We know that individuals who have higher amounts of fitness going into pregnancy tend to have less severe pelvic girdle pain during pregnancy. We know that, fitness can be protective in the preconception period to how individuals are doing in postpartum. Now, that is relative risk. That is not an absolute. You're not going to have any issues, but you're stacking the deck in your favor. There was a study that came out last year that took a fitness index. And so it took a bunch of, I can't remember off the top of my head what they put into this fitness index. But what they showed was that those who had higher fitness going into pregnancy had less severe pelvic girdle pain. And those that show less decline in those fitness tests across their pregnancy also developed less pelvic girdle pain. And to me, that's interesting because it's showing this protective effect based on the physiology in pregnancy. When we are thinking about pelvic girdle pain in general, a lot of people say, well, it's relaxin. It's your hormone that's circulating all the time. Right? And everyone's like, well, no, it's not. And I say, well, we kind of have to have a little bit more of a nuanced conversation because there is something going on in our physiology that's making pain be almost 80%. So almost 80% of women in pregnancy have some amount of pain to some amount of severity for some amount of length. And pain's kind of complicated to measure in research, but that's another soapbox. With relaxin coming through the body, it is creating ligamentous laxity that is preparing the body for delivery. So your rib cage widens, your pelvis widens, and those are normal, natural changes. But when we think about all of our joints in our body, and this is where I say the nuance comes in, we always have this balance between static support of our ligaments and dynamic supports of our muscular structures. And, something like the shoulder, we rely more on dynamic structures because it needs more freedom to move. And in our knee, we have more static support and, there's a lot more stability. In the pelvis, there's a lot of ligamentous support, right? Everyone talks about SI joint upslips. I'm like, are you kidding me right now? The SI joint doesn't move. There's so many ligaments around it. However, when we have a laxity in our static supports, we have to rely more on our dynamic structures. And if we are subsequently deconditioning our muscles while we're losing support from our ligaments, then it could be this, perfect storm for a high amount of pain. So I don't think it's the relaxin, but I think in a hormonal environment of ligamentous laxity, we have to build up our resiliency of our dynamic support. And if our dynamic support isn't there, then we are more prone to pain. And I think that coincides with what we're seeing, that preconception fitness is helpful and lack of deconditioning is helpful for severity of pain in pregnancy.
I've got two questions. The first one is in the pelvic space. What article do you, and I realize it's got to build, and I think it's been wonderful for everyone to understand that because everybody, I think, has unrealistic expectations for what the research can show at a reasonable period of time. So it's great for everyone to hear this process. Go ahead.
And I have two of my faculty that have now been in the research process with me. That. So Rachel, who's been on the podcast, she did a clinical commentary with me, and Jess is part of the systematic review, and they're like, So I really
more
I think
to it than,
I really think it's great for people to have some experience about what it actually takes to put a research paper together.
Totally.
Because it is so much more cumbersome. And so, a lot of people are very critical of science, and of course everybody's got bias.
Sure.
But there is so much more to it than a lot of people understand. And so it's been really cool to also bring some of our faculty into the fold of it and understand that.
So good.
That's my comment, Mark.
As you build in the pelvic space specifically, and you're talking about this kind of you zooming out and what you really want to look at, hormone relationships and timing and training, what article is at the very end of this journey? What needs to be done for you to feel like I got to really explore the thing I wanted to look at the way I wanted to look at it?
In 2019, we had the Canadian Society of Exercise Physiologists and Society of Obstetricians and Gynecologists posted the exercise guideline, and there was very little for them to make finite recommendations around resistance training in that exercise guideline. So I think I would be living the research dream if I could, be any part of a redo of that guideline, because they do them every 10 years to update the evidence. And if in that guideline we have enough research for us to remove top ends and make it very individualized. So our new postpartum guideline, which Margie Davenport, my supervisor, was leading the charge of this for multiple years. I was not a part of the guideline. They posted in that postpartum guideline that return to fitness is personalized, individualized, and should be based on symptoms. And just loved it. And it removed a lot of the barriers around waiting 6 weeks. And then there's a lot of ideas around waiting 12 weeks for resistance training and running. And they said those aren't substantiated. And some individuals are going to go back at 2 weeks and some people are going to go back at 6 months. And it gave a lot of freedom within the framework and saying we are going to need to have a recovery process. There's a lot of biopsychosocial factors that go into postpartum exercise. And there are a lot of very real barriers to getting individuals reconditioned in the postpartum period. If I could see something like that that gave a lot more freedom around resistance training in pregnancy, I would die a very happy person.
You'd be there.
Yes.
We are going to have a whole nother episode, you and I, about your feelings with everything you've learned in the process of research and what it means to operate in a way that we need to as clinicians. This kind of clinician scientist idea, I think you're going to be, there's a whole episode waiting for us to unpack there. So I do not want to open that can right now, but I do want to ask one other question because I can only imagine the older adults, if any listen to this podcast, are thinking, have we lost a hero? Have we lost a champion?
after that deviation, do you feel like your future research world, is it tilting all? Will you circle back to frailty stuff? What's the future for Dr. Prevett in that space?
I know. It makes me sad. I have so many thoughts around the blending of geriatric practice and our pregnancy postpartum.
Interesting.
I can't imagine myself going back to frailty. I think I would be targeting meno. I want to go after menopause, I think, is where I'm going to build, right? Because now I've been involved in some stuff in pregnancy, some stuff in postpartum, and where I would want to bridge is around menopause and around resistance training, pelvic floor dysfunction, and just building resiliency in postmenopausal females. So I kind of see that I'm always going to be trying to blend my geriatric and pelvic spaces into something that is empowerment forward, managing fear, and is focusing on capacity around that space. I kind of think that's where I'll be.
Bringing the older adults back on the scene, but maybe not in the original design.
Yeah, because in the high load resistance training will be there, but it'll be in a contextual factor around menopausal changes and always kind of putting a lens of the pelvic floor in there as well.
Interesting.
That's probably where
what'll be so fascinating to watch your career is as you bump into folks, and this will happen over decades in that menopause space, who got drastically different narratives when they were pregnant or postpartum, partly because of your influence on that conversation.
Yeah, absolutely. Absolutely. And, you know, we're starting to see this as individuals are older when they're having babies.
Yeah.
They're going from postpartum in their 40s to perimenopause directly after. And so they're these spaces which seem like they're really far apart.
Up.
They're cinching up. And so really it's not as big of a deviation as you would think.
Yeah.
Additionally, post-menopause, and one of, you know, you and I have had conversations about this, is that a lot of our pelvic education stops at menopause. And menopause is an accumulating condition where it is the length of time that tissues have been exposed to low estrogen that incur risk. So, example, when you are going through menopause, anything with an estrogen receptor, you're going to notice changes. So brain fog, rage, anxiety, depression in the brain. Yep. We also see a dose response increase in risk based on the time that you went into a low estrogen state. So if you went into premature ovarian insufficiency, so around 35, you got into low estrogen, versus early menopause, where you were going into menopause around 40 to 45 versus going into menopause at the average age of 51 that we see in the US, there is a stepwise increase in risk of dementia. And so if I think about my 50-year-old who's talking about their menopause now, I also want to think about how you feel within your body at 85 when you've had 35 years of low estrogen. And people talk about the bone, which is great, but I'm talking the brain, the heart, where risk of cardiovascular disease starts to level off with men, right? There's a protective effect of estrogen on the heart. And so when estrogen goes down, cardiovascular disease rises in women. And then the bone and the pelvic floor. So that is important. And I think that is not part of the context. And where I really want to come in is like, one, how do we do geriatric specific pelvic floor considerations in the realm of resiliency? Because if their body is 1 rep max living, right, they're at their max capacity for activities of daily living, then their pelvic floor is 1 rep max living too. And they're never, gold line treatment, first line treatment should be conservative management, which is pelvic floor, hopefully plus functional activity. But oftentimes they're given anticholinergic, antimuscarinics, given surgery. Especially our older adults, they're not usually getting access to conservative care first. Yeah. They're usually going med management first or surgical management first. And so I think there's a huge research component that needs to come in there, where we're not just doing pelvic floor muscle training, we're doing pelvic floor muscle training in combination with resistance training, right? Because we want to build functional capacity. Urinary incontinence is considered a clinical geriatric syndrome, just like frailty, because there's constellations of signs and symptoms that incur a vulnerability to a specific outcome, which in frailty, it's just adverse events in the healthcare system in general. And then in incontinence, it's obviously leaking. And so there's a lot, again, of parallels between urinary incontinence in a geriatric population versus frailty in that population as well.
a whole nother sphere,
Yeah, I could talk to you all day.
which we know is just one email away from being discovered at some point in your
1000%.
future. Christina, as we wrap up, and like I said, this is officially part one because I really want to talk about your thoughts on clinical practice and how your space in research has influenced how you see us practicing, and then maybe some advice on how we can get closer to being in between the buoys, I think, going forward. So we'll unpack that. In this parting words, what would you say to clinicians who are getting in the pelvic space, which thanks to you all on ICE division is an escalating amount, an unbelievable level of demand for this coursework? What would you say to them confidently? There's so much more still to be discovered, but you've also learned a lot. There's a lot of existing narratives out there. If someone's just getting into the pelvic space and they're encountering all of these narratives, what would you say to them to kind of boost their confidence or give them some support in their practice of like, hey, I'm telling you, you can do this safely. You should be doing more of this. You can say that that's wrong. Anything that any one narrative that you would like to challenge for these young pelvic practitioners as we sign off?
Oh gosh, there's so many that I can say confidently, like with a one-liner.
Doesn't have to be a one-liner, but just anything out there that you know they're hearing that you're like, no, that one you can push back against and feel confident in doing so from an evidence-based perspective.
Probably most of our modifications are blanket modifications for exercise and pregnancy.
Generic.
Yeah, there is no such thing as you're this trimester, you have to stop doing this, or you're this number of weeks pregnant, you have to get rid of that. The advice that if you were doing it before, you can continue doing it now in pregnancy is actually very good advice. And people hate on it all the time.
Yep.
But I, 12 weeks ago, would not have run a marathon because I was not ready for it. I would have had shin splints and sore feet and all these types of things.
The training age wasn't there.
Yeah, it wasn't there, right? So yeah, my preconception fitness matters for my advice in pregnancy.
Totally.
But I'm going to give them buoys of, hey, if you're feeling heaviness, incontinence, pain, those aren't things that are necessarily going to restrict your exercise, but it may be that we need to have a little bit more of a conversation about how we keep you within the buoys. And that might be 37 weeks for some people.
Yep.
That might be 11 weeks for other people.
But the days of your 3 months, you stop this. Your 6 months, you stop this. Your 6 weeks postpartum, you start this. The days of these generic timeline modifications are gone, and the days of looking at you as you come in with this presentation and thus for you it's this are here.
So here's my one-liner.
Yep.
There is no such thing as a safe or unsafe exercise in pregnancy. There is a one that you are ready for, and there is the one that you are not.
Christina, thank you so much, and we have so much more to talk about. Thanks for being on the show.
You're welcome.